Connected by purpose, driven by passion. Welcome to the Spark Live webinar series, where we gather to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities. Keep up to date on all of Children's Healthcare Canada's webinars, events, and announcements. Sign up for our Spark News e-bulletin by visiting our website at childhealthcan.ca and follow @childhealthcan on Instagram, X, and LinkedIn. Now, on to today's webinar.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your webinar host. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to Indigenous people from across Turtle Island. Children's Healthcare Canada is committed to forging new and deepening existing relationships with First Nations, Inuit, and Métis peoples, and are grateful for the opportunity to share this land as we work to measurably improve children's health and healthcare from coast to coast to coast. We are delighted to speak with our colleagues from Kenja-Wiwentag and the Montreal Children's Hospital. Dr. Amy Shwanda and Dr. Patricia Lee will be presenting From Insight to Impact, Strengthening Services for Indigenous Children and Families in Canada's Children's Hospitals. I would like to briefly introduce our speakers for today. For their more fulsome bios, however, please visit our website at childrenshealthcarecanada.ca. Dr. Amy Shwanda is an Odawa Kwe from Wickwamacon, the unceded territory on Manitoulin Island, where she was immersed in Indigenous education and land-based learning throughout her life. This foundation shaped her path as an Indigenous health researcher dedicated to strengthening Indigenous ways of being, doing, knowing, and reclaiming. Dr. Patricia Lee is a general pediatrician at Montreal Children's Hospital, an associate professor in pediatrics at McGill University, and an FRQS senior clinician scientist at the Center for Health Outcomes Research at the Research Institute of the McGill University Health Center. She's also part of the Northern and Indigenous Child Health Program, where she serves Inuit children and families in the community of Ivwayavik. Welcome all. It's now my pleasure to pass the mic to Dr. Lee.
Thank you so much, Paula, for the introduction. And I was telling Paula earlier, it took me a few months also to practice, for example, Kenja-Wiwentag and other words to know how to say properly. So much appreciated, Paula, for the introduction. And I'm sorry, I'm trying to now do my presenter mode. Here it is. So thank you all for connecting with us today. I wanted to start off with my land acknowledgement by telling you that I'm joining you from the Inuit community of Ivwayavik that you see with the red arrow pointing at the very top of Quebec. It is the most northern town in Quebec, as well as in any province in Canada. And as you can see from this map, there are 11 distinct Indigenous nations in Quebec. The work that I do here in Ivwayavik, which is providing local care for Inuit children, and the collaborative work that I do alongside Amy reflect my commitments to advancing the truth and reconciliation calls to action and honoring the traditional custodians of this land. Amy's conflicts of interest are here, none of which really are real potential conflicts, and I have none to declare. And this community environmental scan and community of practice that we're presenting are funded by 2 CIHR grants that are supported by these team members across the country, as well as a few of our research networks that we belong to. So POPCORN, which is the Pediatric Outcome Improvement through Coordination of Research Networks, and the Pediatric Inpatient Research Network in Canada. And to provide some context, we started engaging in this work because Indigenous children are the future of their strong cultures and their resilient communities. Yet there are ongoing disparities in hospital care for Indigenous compared to non-Indigenous children due to medical colonialism, anti-Indigenous racism, and other structural determinants of health. So the objectives of our webinar today that have been shared with you are first to describe the gaps and opportunities in Indigenous-focused health services and programs in Canadian children's hospitals, to describe a community of practice that is fostering knowledge mobilization towards culturally safe care for children and families in the hospital setting, and finally, to identify the achievements and challenges with culturally safe practices, including smudging, Indigenous navigation programs, and integration of Indigenous concepts of child health and wellness across Canadian children's hospitals. Amy and I began this work several years ago with a CIHR planning grant aimed at identifying services for Indigenous children in Canadian children's hospitals. Our goal was to understand the strengths, challenges, variations, service gaps, and what resources were out there to inform further research and advocacy, and obviously clinical care. So to achieve this, we conducted an environmental scan of publicly available documents and kind of synthesized this in a narrative synthesis. We also complemented with semi-structured interviews that were carried out between June and November of 2024. And these interviews were analyzed thematically with member checking to ensure methodologic rigor. We use three concepts or three conceptual frameworks or principles to guide our thematic analysis. And most of you already know these. First, there's the TRC calls to action, where actions 18 to 24 relate directly to health. Joyce's principle that resulted from the brutal and avoidable death of Joyce Echaquan, an Atikamekw mother in an emergency room in Quebec. And this principle aims to guarantee the right of equitable health and social services for all Indigenous people without discrimination. And lastly, Treaty 6, Medicine Clause of 1876, which was supposed to promise full health care and medicines for all First Nations people. So there were a total of 17 eligible hospitals, 14 that are standalone children's hospitals, and 3 that provided specialized secondary, tertiary pediatric care. And online descriptions of these Indigenous services were available in all but 1 hospital. We were able to reach 14 of these hospitals by interviewing 19 participants, and the majority of them were female, with over a quarter of them identifying as First Nations, Métis, or Inuit. We interviewed a range of healthcare professionals and healthcare staff, including, physicians, social workers, program directors, Indigenous health researchers, Indigenous health and wellness consultants or navigators, and Indigenous patient engagement specialists. And here are the themes that were identified from the interviews. We'll go through each of these in the following slides and complement with the data from the literature search. So across the hospitals, we observed considerable variation in programs, services, and spaces designed to meet the distinct healthcare needs of Indigenous children and their families. All but 1 hospital offered such initiatives, and some of these were embedded within the hospitals, while others delivered them in partnership with community or provincial organizations. And these programs range from kind of newly developed or evolving ones to long-standing initiatives. As one participant noted, truth and reconciliation was only about 10 years ago, and this program has existed well before that. These programs and clinics varied widely across the country. There were differences in how Indigenous-led they were and in the representation of local Indigenous communities and staff. Some programs had Indigenous staff integrated into the core team, while others relied on partnerships with external organizations. All of these programs provided cultural supports, but what this actually entailed differed by site. About a quarter of hospitals had Indigenous councils or advisory groups such as wisdom councils, elder circles, working groups, parent partner groups, and these groups helped guide care and services. And it was quite refreshing to see that about half of the hospitals, although it's not enough, obviously, but half had integrated Indigenous healing spaces. or that they were in the process of building them during the time of the interviews. And these included gardens or spaces for smudging or a smoke lodge. For theme 2, Indigenous staff were essential to delivering these programs, yet their numbers were limited and their responsibilities were broad. This heavy workload made it difficult to meet the growing needs and had the potential to lead to burnout, which, as one participant stated, can be incredibly devastating. The key point on this slide that I wanted to point is that all but one hospital had Indigenous patient navigators at the time of the study. However, their roles, responsibilities, official titles varied across institutions, and some navigators served the broader community beyond the hospital. We also found significant variation in the recruitment and retention of Indigenous staff, as well as in physicians' awareness of these services, meaning that they were not always optimally utilized to support culturally safe care. For theme 3, we identified gaps and variations in hospital-led strategic approaches to Indigenous child health. When strategies existed, they were typically embedded within a broader, larger equity, diversity, and inclusion plan, with few hospitals having a standalone strategy focused specifically on Indigenous health. As a result, the implementation of culturally safe care varied because few were actually mandated from top down. Yet notably, a few hospitals operated under provincial legislation that required culturally safe care for Indigenous children. Participants also reported significant gaps in collecting data on Indigenous identity, the care provided, and the related outcomes. And without this systematic identification, Indigenous children were not routinely connected to appropriate services. As one participant explained, if I don't think of it or if a family doesn't talk to me about it, then I don't connect them. Similarly, most participants reported no systematic process for monitoring care or outcomes, apart from self-initiated mechanisms such as the hospital ombudsperson. As one person noted, so the whole opportunity to improve care was not really happening. Some hospitals, however, described using surveys and talking circles to gather ongoing feedback on services, so being more proactive and not just relying on a complaints process. Participants also highlighted that although cultural safety training exists, most were not mandatory, and as one participant put it, it's a lifelong kind of thing. And lastly, participants highlighted that we need to recognize the strengths of Indigenous children and families. And to quote one participant, different things originate with different people. And so it's important that we're not all painted with the same brushes as well. We need to be looking from strength-based perspectives and not deficit-based. So from this environmental scan, we concluded the following recommendations. Hospitals should prioritize Indigenous staff retention and capacity. Further, hospitals should also prioritize communities-led data collection to improve care and outcomes. And they need to continue to implement local and context-specific mandatory cultural safety education. And lastly, our participants voiced the need to increase visibility and share the knowledge of these programs across hospitals as well as within the hospitals to celebrate and learn from the wins and find solutions for the challenges. And that's how Amy and I applied for the second CIHR grant that focused on dissemination of these results and to create a community of practice to continue the discussions and promote networking among programs and services. So far, we have 54 members, and the number is increasing, with monthly sessions spanning from 13 to 18 attendees per session. Participants come from a wide range of backgrounds, including Indigenous staff, such as navigators, social workers, consultants, engagement specialists, administrators, all types of clinicians, including nurses and doctors, and we also have a patient partner. The overarching goals are to share experiences and our learnings from providing care for Indigenous children, and to advocate for improved culturally safe care locally and nationally. And now Amy's going to speak about the topics that were discussed during the first 3 sessions. And just to note, some of what she's going to share does come from the community of practice, but some of it also comes from her extensive experiences working with other hospitals, so not just children's hospitals across Canada. And so we'll go from there.
Thank you, Patty. When we talk about a community of practice in the context of Indigenous health, we're really talking about creating spaces where healthcare systems can learn to do better, not just in theory, but in the day-to-day reality of caring Indigenous children and families. So when we brought in the individuals, we wanted to know that this is not just about sharing best practices in a boardroom. It's about the nurses who want to support a family's request to smudge. It's about the patient navigator who gets called auntie by the families they serve, even though it's nowhere in their job description. It's about understanding that Indigenous concepts of health and well-being are fundamentally different from Western medical models, and that this difference matters. So here I want to talk about 3 interconnected aspects of this work: how we create policies that support traditional practices like smudging, the reality of what Indigenous patient navigators actually do versus what we ask them to do, and the broader framework of Indigenous concept of child health, and that grounding all of this work together. So let's start with something concrete. Smudging in hospitals. We're all familiar with it. We all know it exists for the most part. And so for many Indigenous families, smudging isn't always optional, it's essential. So when a child is sick, when a family is facing a difficult diagnosis, when someone is preparing for surgery, ceremony and traditional medicines provide spiritual, emotional, and physical support that Western medicine simply cannot offer. The 4 medicines of sage, sweetgrass, cedar, tobacco. These aren't just a nice to have, they're medicine. But here's what happens in most hospitals. A family will ask to smudge. Maybe they're told no, outright because of fire codes. Maybe they're told they can go outside, even if their child is in the ICU and can't be left alone. Maybe they're told yes, but. And then given so many conditions that it becomes impossible. So hospitals started creating smudging policies, and this is where good intentions can always go sideways. I've seen policies that require 48 hours notice. I've seen policies that require a fire extinguisher, a cultural advisor, or what have you. And I've seen policies that restrict smudging to certain rooms at certain times, or perhaps even outside in the middle of winter. And while any policy is better than no policy, we have to ask, whose needs are these policies really serving? A family in crisis doesn't operate on a 48-hour notice schedule. The need for ceremony doesn't wait for business hours. And requiring extra personnel or special room creates barriers that don't exist for other forms of spiritual care. No one requires a priest to give 48 hours notice before performing last rites. The best smudging policy I've seen are simple. They clearly state that smudging is permitted. They provide the necessary safety equipment. They train staff on what to expect. They designate spaces where it can happen safely. They make it as normal as any other aspect of patient-centered care. But here is the critical piece we spoke about. Policies alone don't create safety. You can have the perfect smudging policy on paper, and yet our families will still be afraid to ask because they've learned from experience, maybe in this hospital, maybe in another one, that asking for traditional practices invites judgment, delay, or outright refusal. So supporting patients means more than policy. It means staff who understand why smudging matters. It means seeing the relief on a grandmother, a mother, a father's face when she's told yes instead of, let me check with the supervisor. It means recognizing that when we support traditional practices, we're not just being accommodating, we're actively supporting healing in ways that Western medicine cannot do alone. This is where the community of practice becomes essential. Hospitals need to be learning from each other. what works, what doesn't, what are the common barriers, how have other institutions solved these problems. When we're all trying to figure this out in isolation, we repeat the same mistakes. When we're learning together, we can actually make some progress. And so this takes me community of practice with our patient navigators. I want to talk about the people who are often doing the most to make these policies work in practice, Indigenous patient navigators. And these positions were created to help Indigenous families navigate healthcare systems that are, frankly, confusing and often hostile to them. These positions represent a recognition, however inadequate, that Indigenous patients face unique barriers to care. But here's where it gets complicated. Let's talk about what the job description says versus what the job actually is. The job description might say, coordinate appointments, explain medical procedures, connect families to resources, attend medical appointments as requested. The reality looks more like this. You're explaining to a family why they can't take their child home for a ceremony. You're advocating for a mother who's been reported to child services. You're wanting to use traditional medicines alongside Western treatment. You're sitting with a family while they're holding their child just recently diagnosed with cancer, and you're fighting with administrators about why a family needs more than one visitor during their visit, when their entire kinship network is their support system. But your employer sees things, and then there's this beautiful, complicated reality. Families start calling you auntie or uncle, and you just feel like this immense responsibility to the family you're caring for. Because in our communities, that is what you are. You're the person who shows up, who advocates, who cares beyond the transaction of a job. You have become kin. But your employer sees things differently. They might worry about professional boundaries. They may tell you that you're getting too involved. They might remind you that you're supposed to maintain objectivity. But here's what they don't understand. In Indigenous worldviews, there's no such thing as helping someone without being in a relationship with them. The Western model of professional distance is itself a cultural construct, and it's one that doesn't serve Indigenous families well. So navigators are constantly negotiating this tension. How do I do this work in a good way, according to my cultural values, while also satisfying an employer who operates from a completely different assumptions about what helping looks like? And so now we have trauma on both ends. And here's the part we don't talk about enough. There's trauma on both ends of this equation because, one, our families are experiencing trauma. They're watching their child suffer. They're navigating a system that has historically harmed Indigenous people. They're dealing with current discrimination alongside historical trauma. But the navigators are also experiencing trauma. They're absorbing stories of pain and loss day after day. They're fighting battles against institutional racism while trying to maintain their own well-being. They're often the only Indigenous staff member in their department expected to represent and advocate for their entire community. They're witnessing the same systemic failures over and over, watching children and families suffer from problems that could be prevented if the system would just change. And yet many navigator positions don't come with adequate mental health support or professional development opportunities. They're often term positions, precarious or renewable, always uncertain. They're paid much less than other healthcare professionals, even though they're expected to be cultural experts, translators, advocates, educators, and support workers all at once. So in this community of practice for patient navigators was shared that many individual people, hospitals, they're failing on so many fronts. So we need to offer peer support, shared learning, advocacy for better working conditions, and validation that their work they're doing is both essential and impossibly hard. So now this brings me into my next slide of Indigenous concepts of health and well-being. And I want to look at the bigger picture. And so Western medicine tends to define child health narrowly with physical symptoms, developmental milestones, absence of disease, while an Indigenous understanding of health is holistic and relational. In Anishinaabe teachings, we talk about health as balance. We talk about the mental, the physical, the emotional, and the spiritual. We understand that a child's health is inseparable from their family's health, their community's health, their connection to land and culture, their sense of identity and belonging. This means that a child can be medically healthy by Western standards, but deeply unwell if they're disconnected from their language, their culture, their community. Conversely, a child with a chronic health condition can still be well in all the ways that matter most, surrounded by love, embedded in culture, and connected to their identity. So when our healthcare providers understand this, they practice medicine differently. They ask different questions, they make different recommendations, they partner with families rather than simply prescribing to them. And so when we think about this, an Indigenous informed approach recognizes that asking a family to stop smudging is asking them to give up a key part of their spiritual and cultural practice, and that the stress of cultural disconnection might itself harm the child's health. So instead, you problem solve together. Can we have some type of ventilation if it's mandatory? Can we adjust the child's medication if it's mandatory? Can we think about this in a way that honors both medical and cultural needs? So I started thinking about legislation support practices, and here's something else that's critical to understand. Some of the progress we've made in supporting Indigenous health practices is protected by legislation. Laws and policies that require healthcare institutions to accommodate traditional practices, that protect the right to cultural safety, that mandate consultation with Indigenous communities. But legislation can always change. Governments change, political will shifts, funding gets cut, rights that felt secure can be rolled back. And this is why in this community of practice is so important. We want to look at we can't rely solely on a top-down mandate. We need to have grassroots change. And so if we have healthcare providers who understand why this work matters, who still advocate for Indigenous patients regardless of what the current policy says, who will push for better even when they're not legally required to. We need to be building a culture of Indigenous cultural safety that goes deeper than compliance or a checkbox. We need healthcare workers who choose to do better because they understand it's the right thing to do, not because a policy tells them to. And we need to be documenting what works. When legislation is threatened, we need evidence, stories of better outcomes, examples of successful programs, research that shows the impact of culturally safe care. So a community of practice in this area can be the place where we gather that evidence and prepare to defend these practices when they come under attack. So where does this leave us? In this community of practice around Indigenous health and pediatric setting has to hold all of these pieces together, the practical work of implementing smudging policies, the live reality of patient navigators who are doing essential and exhausting work. So the bigger vision of what health means through an Indigenous lens and the political understanding that all of this can be taken away if we don't actively protect and expand it. But this work, it is hard. It requires healthcare systems to fundamentally rethink how they operate. It requires non-Indigenous healthcare providers and administrators to examine their own biases and learn new ways of practicing and doing. It requires institutional commitment and resources. It requires Indigenous staff to be supported rather than exploited. But it's also possible. I've seen hospitals where families feel safe to ask for smudging. I've seen patient navigators who are properly supported and valued. I've seen pediatricians who truly understand holistic Indigenous concepts of health. So when we learn together and share what works, support each other through the challenges, and refuse to accept that the current system is good enough, that's when real change happens. And now I'll pass it back over to you, Patty.
Thank you, Amy. So in summary, it's been a privilege to learn and learn from and work alongside the many individuals who are driving the strong and resilient programs across children's hospitals. While we are all at different points on the journey to address the TRC calls to action and Joyce's principle, even the most advanced programs, as Amy alluded to, including those, supported by provincial legislation, face ongoing challenges that threaten their continuity. And here I just have a recent CBC report highlighting, a proposed change that could remove the provincial mandate for Indigenous education of Alberta lawyers, which reminds us how fragile progress can be. But despite these potential setbacks, there remains an unwavering community of Indigenous and non-Indigenous staff and clinicians across the country who continue to champion the highest standards of culturally safe care. And that's the end of our presentation. Thank you very much for listening. And we are opening the floor for discussion, for questions and discussion.
Hello, everyone. So thank you so much, Amy and Patricia. I see that there's a couple of questions coming in. Don't hesitate to keep typing away with your questions in the question box. Patricia, you've spoken about policies around smudging and other ceremony, around Indigenous navigators. Do you have sample policies or a way of helping folks evaluate their current policies in light of what you've shared today?
Thanks for that question. And I apologize, Amy had to run off, so she's not able to attend the Q&A. But these are things that we think about and we talk about all the time. And in fact, in our community of practice, from these 3 sessions that we've had and these 3 topics, our goal is to do some of this. So we've started to get some of the smudging policies and kind of put it together so that we can learn among ourselves. And I think with the community of practice, we're trying to figure out, how much and like what parts can we share publicly, what parts are for more kind of internal use, but that is the goal. So, apart from, the usual kind of manuscript publication, we're also trying to be like accessible to the practitioners and staff and people on the ground. So that last email, and maybe I'll just put that back up again. For myself or our research coordinator working with us on this project, please do feel free to contact us, and we would be happy to share with you some of these tools that are that we're allowed to share. Essentially, same thing with the patient navigators. We're putting together all of the job descriptions, and then we're trying to synthesize, what's common, what's different, and basically share all of these learnings.
Wonderful. There's been a few comments in the chat box about various policies. Some have commented on the need to either establish them or certainly review them. So I think your community of practice is likely to be very helpful to a number of people. Can others from the audience join the community of practice, or is it closed at this point?
I know, the goal of this was initially invite everybody, because I think everybody has so much to bring in, and I think that that's what we want to do. We want to continue to invite everyone. There's a part of me that's very careful about the community of practice, so we will ask everyone in it, is it okay that we continue to invite? Before I knew I should have figured that out before I attended today, but please do reach out to us. I'm going to share again the email, because I do want to hear from you and see how we can connect and how we can keep adding people. So we have been adding people on as, we've been referred various people, and obviously, it's a great place for everyone to learn and share, and that is the goal. But we will ask everyone on the practice right now, just to be sure that we are collaboratively that we agree with this, or how do we move forward at this point?
Absolutely. Fair. Um, are there examples of Indigenous-led programs that are successful currently in promoting culturally safe care in children's hospitals and other healthcare services that serve children and youth?
Absolutely. And I think a lot of you represent some of these hospitals who are on the call right now, represent, or you're in those institutions, those hospitals that are doing really amazing things. And like I said, if for some of other hospitals who are not, who are a little bit on less advanced, let's say, on the spectrum or on this journey, I think we all look up to these programs, and it's not to say that not everyone is trying. There's so many champions on the ground, so many people working hard to make things better. Um, so some of the things that, are really cool to highlight, I think, there's the Awasisak program in Alberta, in Edmonton. They have a bunch of documents available on their website that describes how their Indigenous-led program was created, initially with talking circles in the communities to really figure out what is it that people needed, and really driven by the communities to create this really, multidisciplinary support and care and service in Edmonton at the Solely Children's. In BC, there's like this really also cool program that integrates, they have obviously a big team for their Indigenous health services, but within that, there's Terrace Desnamy, who is the program manager of Indigenous health team quality and safety. And they've really embedded, you know, um, Indigenous health into their quality and safety reporting mechanisms. I heard him present on this recently, and this wasn't part of our environmental scan, but really neat what they're doing in terms of identifying, whether Indigenous patients were involved in patient safety events and having a whole system to respond to that, not just identifying it and then, well, what do we do with it, but actually having a system and infrastructure in place to respond to the needs and support the families who may be impacted by these patient safety events, and identifying whether discrimination was anti-Indigenous, racism or discrimination was part of the mechanism of that error or safety event. Um, Across the country, there's a lot of really neat, Indigenous like consultants, wellness, youth leaders who do all kinds of, at London Children's, they do all kinds of activities with the youth and the families, bringing the culture into the hospital to help with healing, promoting a lot of arts-based therapies uh, in the hospital setting, which is also, just really wonderful and needed. So it's these are some of the examples, but like I said, I think a lot of you are working in some of these institutions, and if you don't know about your local kind of programs, I think that's another thing that's really important to ask around and to figure out what's available for Indigenous children and families.
That's fair. We can all work in the same organization, but not know what different parts are doing. So that's an important reminder. Holly comments that their organization has spiritual care spaces throughout the hospital, but accessibility can be an issue for patients that may have to leave their units. She'd love some education or alternative suggestions about what could be done at the bedside for those patients.
Yeah, and I'm gonna say I'm not going to answer fully to that because that's not my specialty, and I'm sorry that Amy's not
Fair.
here to support it. But I can certainly think of, whether there are elders or other, you know, um, Indigenous kind of cultural like engagement specialists who, yeah, who are on the teams who could actually provide that at the bedside, as you're saying. Um, and we have to recognize too, like across the country, we're talking about hundreds of communities with hundreds of different kind of distinct identities. And so that would be really important to match, and meet the individual distinct needs of that person at the bedside. I'd love to hear if others have any experiences with that and to hear what people have done. But I think it takes that initiative to listen and hear, first of all, what families need, and then try to figure out the solution for it. As Amy said, it's a lot of these are fundamental rights, and so it's not, oh, sorry, we can't do it, but okay, let's try to figure it out, and recognizing that we do face a lot of barriers ourselves as clinicians or bedside people or admin people at the hospitals, but we can definitely try. Thank you. Yeah, thank you.
Another question. Can you share more about Jordan's principle and how it's being integrated or supporting change?
So I guess there's Jordan's principle and Joyce's principle. And just to address the first question about Jordan's principle in terms of, basically ensuring that children, Indigenous children, get the care that they need in their community and or are supported for the care that they need. And that principle kind of derived from the story of Jordan, who lived his whole life in a Winnipeg hospital and was never able to return home and be in his community and die in his community because of these kind of legislation between provincial and federal funding and who's going to fund what for this and that. And as an ongoing fight
Yes.
in the court of law. And as many of you know, Cindy Blackstock is a huge, advocate and fighting at the front lines for a lot of these cases. And sorry, the question was about how it's being
And Joyce's principle as well, and how it's being integrated or supporting change in organizations.
Yeah, I have to say, like with Jordan's principle, it takes the person to apply for it, right? So I do
Right.
see, I can only speak for my kind of hospital setting where it's the individual clinicians and or social workers and or nurses or supporting staff who say, okay, this doesn't make sense, or this kid needs this. And instead of saying, well, we can't do it, it's right, we can apply for Jordan's principle or the Inuit Child First Initiative kind of equivalent. So I think for those who don't know about it or who haven't used it, I think it's super important that you learn about it and understand what children have the right to and how it can certainly help you get services, for the kids that they need that otherwise you would have said, oh no, that's too expensive, or it's, we can't afford it, or the family can't afford it, or it's not something that we offer. Well, be creative about those solutions and using
Right.
Jordan's principle. Joyce's principle, it's interesting as well. When we did our interviews, it was less kind of implemented across the country, but I think the idea of culturally safe care and, care without discrimination is being implemented in various ways. As I mentioned, the BC Children's experience with having, patient safety reports that have to do with whether discrimination was a factor and, kind of supporting families through that. And the various cultural safety trainings that people get that, as we said, are not necessarily always mandatory and not always ongoing. Sometimes it's a one-time thing, and then you're supposed to kind of know everything. And I think a lot of institutions, like my own experience, one also are trying to figure out how do we support Joyce's principle. We know that the whole point of Joyce's principle and kind of the underpinnings of it is that it has to come from the communities. The communities have to tell us also what are the issues and how to how to bring it forth into policies or advocacy or practice. So I think how hospitals are doing it is with these circles, with these more proactive ways of gathering voices to identify the challenges and gaps to then address Joyce's principle. But as everyone has said too in the chat, like there's so much that is being done, but there's so much still to do. And I think a lot of you who are here are on that, advocacy and on board for all of this. But it's kind of carrying everyone else who's not quite there yet with the knowledge, with the understanding, with the, just wanting to be part of this important work of giving fundamental rights and cultural safety for Indigenous children. That's a lot of work that I think we're trying to pull towards us too. Yeah.
And the last question, it seems, unless some comes in while I'm talking, are there considerations to involve Native friendship centers in your work?
Yeah, and thank you, Becky. Becky always has wonderful questions. I do know that some hospitals are very closely tied to their community centers that provide Indigenous supports, friendship centers being some of them. I think there has to be a lot more work around that, and I think it's the same idea that each hospital, from what we're hearing, what we're understanding, is on various points of this path and this journey and this connection. So I know, like, some of these kind of partnerships are not formal, and I see people who are, social workers who connect with these friendship centers as a group, and then you're like, okay, well, why aren't we as a hospital, doing this too, right? So I think it's a great point, Becky, and maybe we should talk a little bit more about that in our community of practice, like how are hospitals connecting with the community organizations, and how can we do this in a more kind of partnered and cohesive, comprehensive way. So thanks for that question.
Thank you so much. That's the end of our time today. You've gotten a number of comments in the chat about this amazing presentation and the value people are taking from it. I want to thank you, Amy and Patricia, for sharing your time and expertise with us today. Thanks to our audience members for joining in. We know how busy everyone is, and we hope you depart with some practical knowledge to bring back to your organization. In the weeks and months to come, we have Spark webinars. On December 17th, we'll host Child Maltreatment in Young Children, Evidence and Insights from the Pandemic. On December 18th, we will be hosting Advancing Youth Suicide Prevention, Learning Across Borders with our sister organization in the States, the Children's Hospital Association. In Spark Conversations podcast in November, we released the Right-Sizing Children's Healthcare, the critical role of community-based developmental care. Listen in as Dr. Catherine Smart discusses community-based developmental healthcare in right-sizing healthcare systems for children with guests Jennifer Churchill and Allison Morrison. Join us at the Hyatt Regency in Calgary from May 31st to June 2nd for our annual conference. Registration will be open early in 2026. Nominations for our Innovation and Impact Award will be accepted until December 22nd. Check out the conference platform for more details. And lastly, Spark Impact is Children's Healthcare Canada's knowledge mobilization, consultation, and support service for child health and health system researchers. Through Spark Impact, Canadian researchers can access knowledge mobilization specialists for advice and guidance on your knowledge mobilization plans in your grants, as well as a variety of knowledge mobilization products and services and tailored supports to help you achieve your goals, expand your reach, and improve research impact. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our website. Thanks again for joining us today. Thanks to our wonderful presenters and this great presentation, and hopefully we'll see many of you back here soon. Bye for now.